Hello everybody, welcome to Nice and welcome to this innovative webinar forum to present to you on behalf of the European Association of Cardiovascular Imaging, the latest in a series of webinars concerning multimodality imaging to guide transcatheter valve interventions. My name is Prendergast. I'm an interventional cardiologist based in London, UK. And I'm very pleased to be joined this evening here in Nice by my friend and colleague Maurizio Taramasso, a cardiac surgeon with interventional skills based in Zürich, Switzerland. And we're also joined by Skype satellite from New York by Becky Hahn, who many of you will know is an imaging expert extraordinaire. Our subject this evening is the tricuspid valve, for many years known as the forgotten valve. And our mission this evening is to make it a memorable valve, not only in terms of the imaging modalities that we need to explore, but in terms of the new transcatheter technologies which are emerging for its treatment. We've recognized for many years that the tricuspid valve is very frequently diseased when we assess it by means of echocardiography as part of our routine practice. But because we have not had good tools for its treatment by means of surgery or transcatheter technologies, it's often been ignored by clinicians, both cardiologists, general physicians, and gerontologists as something that is deemed for medical therapy, conservative management, and poor outcome. We recognize that a large proportion of the patients that we identify are not treated, that the majority of cases are secondary to other diseases, either of the heart or the lungs, with so-called functional tricuspid regurgitation, and reflecting the fact that we focus on these patients very late in the natural history of the disease, that surgery is usually a very high-risk undertaking in isolation and therefore very infrequently performed, and equally reflecting the fact that it is a manifestation of advanced disease, that medical therapy has very little impact on the natural history. The tricuspid valve anatomy is something that we don't recognize and learn very much about at both undergraduate and postgraduate training level. It's important because it has very fundamental anatomical adjacencies, if we could see the next slide, which make intervention in this space difficult and challenging. Firstly, the right coronary artery is very close to the circumference of the tricuspid valve, as we shall hear, and the atrioventricular node in the triangle of Koch is also threatened when we perform interventions in this anatomical space. Challenges for intervention are the fact that the annulus is often elliptical in nature, and also that disease processes are usually not accompanied by calcification to allow easy deployment of transcatheter or surgical devices. Next slide. Nevertheless, in the field of device innovation, many innovative technologies have come our way in recent years, tackling different components of the tricuspid valve complex, and we shall be covering some of those newer technologies in our hour together this evening. And the rate of progress has been very rapid, largely within the last 6 or 7 years. But it's important to point out that the majority of these devices still are being applied in very small numbers in selected centers around the world, and these technologies are not accessible to the majority of our patients in routine clinical practice. So in our hour together, the objectives are to understand the strengths and the limitations of multimodality imaging in identifying disease of the tricuspid valve and determining treatment options, to learn more about the latest cutting-edge technologies, both in surgical and interventional terms, and to use a series of case presentations to illustrate the complexities of the disease pathophysiology and the ways in which imaging is fundamental to guide the planning and the execution of our procedures. So after that introduction, it's a great pleasure to hand over initially to Becky, who is going to walk us through the key elements of imaging the tricuspid valve, the difficulties and the challenges associated. Becky.
Great, thank you so much. I'd like to just start off the webinar first thanking the European Association of Cardiovascular Imaging for inviting us, but to have the audience participate and attempt to answer this first question. What are the important echocardiographic parameters used for assessing TR severity? Morphology of the valve, vena contracta width, color Doppler jet area, proximal flow convergence measurements, or all of the above?
So thank you for that opening question, Becky, just to get people tuned in. So if our participants could vote on that question, and while we're waiting for the outcome, Maurizio, we've talked about the scale of the disease and how much of it presents, but where are these patients hiding at the moment? Are they in your clinic? Are they in my clinic? Where do they exist?
It's a good question. Probably they are a bit everywhere. We know that there are a huge amount of patients that could benefit from a treatment. We still don't know which are the parameters to really guide our clinical indication. So we know that some of the patients are probably too late in their natural history to get any benefit from any treatment. For sure, we know that we don't see those patients that much how they are probably are. So we should probably also work a bit on the referring process. And
so if we're going to improve the management, we need to go looking for the patients first of all.
Absolutely.
So Becky, we've got feedback from our question here, and by far the majority of our participants this evening, 90% of them, tell us that all of these parameters are important. Are they right?
They are indeed right. If we could go to the next slide. This slide is a summary slide of the various parameters that are used in our current guidelines. And you can see, if you click once, Maurizio, that indeed the two-dimensional imaging of the morphology, both of the tricuspid and the right heart, are one of the first things that we do, but then we go ahead and use all of our tools, color flow, as well as pulse wave Doppler and continuous wave Doppler, to fully assess the severity of regurgitation. And this is where we have still some work to do as far as the grading of severity. Next slide. So again, I'm going to start off with just the tricuspid morphology and the right ventricular geometry. And you can see here that some of the measurements that have been shown to have a bearing on outcomes, both for recurrence of TR after repair, such as the annular diameter or the tenting height, tenting area, but also are surrogates for the severity of tricuspid regurgitation. And so we like to measure, again, annular diameter in the four-chamber view, as well as the tenting height at end systole and tenting area. But in addition, we know that the right ventricular geometry now plays a very important role in the tenting. And as you have more dilatation of the mid-ventricle or the septum, we have displacement of the papillary muscles, which will lead to further tenting of the leaflets and therefore determine outcomes. Next slide. So we don't just have echo, although I want to remind you that echocardiography, again, is the first test, diagnostic test of choice for all guidelines. And we also have CT, and we have cardiac magnetic resonance imaging. And we're still learning about the utility of these two other modalities, but certainly CMR has really laid the groundwork for quantifying volumes, and although we're still learning about right ventricular volumes, given the complex contractility pattern of that ventricle, I think we will be using all modalities to assess right heart as well as the tricuspid valve. Next slide. And so again, this summary slide of the ASC guidelines that show us all the parameters that we can use to gauge severity rely heavily on color Doppler flow imaging, as it does on the mitral valve. Next slide. But I want to point out some of the pitfalls of using those parameters and how we are now going to advance the grading schemes by using some new parameters, hopefully that will be proven in some of our studies. The first thing is to look at color Doppler. And we know that, first of all, that severe wide open tricuspid regurgitation may be of very low velocity and therefore difficult to actually planimeter the area. But we also know that color Doppler jet area is dependent on the driving pressure, so the momentum of that jet. And consequently, in the setting of tricuspid regurgitation on the right side, where we have low pressure, that color Doppler jet will actually be smaller than it is for the mitral side for the same regurgitant orifice area. And so for many years, one of the reasons we now are dealing with a problem of late tricuspid regurgitation is the underdiagnosis of the severity based on color Doppler imaging. Next slide. The other thing about tricuspid regurgitation is the elliptical or crescent-shaped, and in this case, a stellate-shaped orifice, given the 3 leaflets and the coaptation of those leaflets. We know that the longest coaptation is between the anterior and the septal leaflets, and that's what you see here in this transgastric view of the tricuspid valve, and consequently using a single measure of vena contracta diameter will not actually describe the complexity of this jet. Next slide. In addition, the only way that we have of quantifying regurgitant orifice area and regurgitant volume has been the proximal isovelocity surface area method, PISA method. And the PISA method obviously relies on there being a single jet, a circular orifice, and a flat surface where that orifice lies. And all of those assumptions do not hold for the tricuspid valve. We have multiple jets most commonly. We have non-hemispheric jets. We have this low pressure side, and the shape of the hemisphere or hemiellipse is very much dependent on those low pressures. And so consequently, we now believe that the PISA quantification will underestimate the severity of regurgitation on the tricuspid side. Next slide. So we know that some of the new methods, the new techniques that will be certainly coming out in the literature soon include the use of multiple locations of vena contracta or an average vena contracta, 3D vena contracta areas, so using color Doppler. In addition, calculating the regurgitant orifice area using quantitative Doppler, and then finally attempting to correlate the Doppler and echocardiographic measures of severity with cardiac MR. Next slide. Early work from our core lab, and this has been accepted for publication, has shown that you can use the average vena contracta diameter from 2 orthogonal views. That's the upper right-hand corner. You can also equate 3-dimensional vena contracta to quantitative Doppler EROA. That's the upper left-hand graph, where you see a nearly perfect correlation between those two measures. And then if you look at the EROA by PISA or the regurgitant volume by PISA, you can see that PISA underestimates both the 3-dimensional vena contracta area and the PISA EROA by almost 2-fold. And that goes along with, obviously, our belief that the PISA hemisphere is actually a hemiellipse and a very complex structure. Next slide.
So Becky, that's fantastic, a masterful overview of the complexities and the difficulties of imaging. We already have some questions coming in which aren't directly applicable to your talk, but it does remind me to remind our audience that any questions are very welcome over the next 45 minutes or so, and we will be leaving some time aside at the end of the webinar to address as many of those questions as we can. And those which are germane to specific elements of the presentations we will pick up as we go along. But Becky has taught us that imaging is key to diagnosis. It's also key to assessment of severity. And as we shall learn, it's key to the planning of interventions. But imaging, of course, is really demonstrating anatomy and function in synergy. And we mustn't forget that anatomical understanding is fundamentally important in this particular area. So Maurizio, it would be wonderful if you could talk us through the anatomical considerations from both a surgical and an interventional perspective.
Absolutely. And in particular in the tricuspid field, I think that deep knowledge of the anatomy of the valve and of the subvalvular apparatus is particularly important in understanding what we are doing and what we need to do to improve our results. We already mentioned that the vast majority of etiology of TR are functional. But what does functional mean? Actually means that the leaflet and the subvalvular apparatus are not affected by organic disease, by organic alteration, and that there are two main anatomical alterations that leads the valve to leak. And one, the most important, I would say, is the annular dilatation, that actually is an asymmetrical annular dilatation which occurs mainly in the anterior-posterior direction, so in correspondence of the valve which is connected to the free wall of the left ventricle. And then of course, the more severe is TR, the more dilated will be the RV and the more displaced will be the papillary muscle. And this will lead to a certain degree of tethering of the valve, so the leaflet of the valve will be tethered toward the apex of the ventricle. And taking into account that these are the two main mechanisms of functional TR, so annular dilatation and leaflet valve tethering, we should understand that the therapeutic target where our interventional tools are targeting are mainly two. So the reduction of the annular dimension, so we have annuloplasty devices, we will see later on in the presentation, and then we have some leaflet or ventricular devices. So the first group will mainly address annular dilatation, the second group will mainly address valve tethering, and then we have a certain number of heterotopic and orthotopic valve replacement. And it's absolutely important, as you mentioned, to have a deep understanding of the anatomy. First of all, the access. Most of the intervention that we perform, transcatheter for the tricuspid valve, are delivered through a transvenous access, so from the jugular vein or from the femoral vein. Most of them from the femoral. You can easily see that the angle between the inferior vena cava and the valvular plane is more steep than the one between the jugular and the valve. Here I'm opening the roof of the right atrium, and you can see how the surgeon look at the valve during surgery. So this is the so-called surgical view, which is also the one that we see when we perform 3D surgical view echo. You can easily see the three leaflet configuration, where this is the anterior leaflet, which is the bigger one. Then here on the right we have the posterior leaflet, which is the smallest one. And then here attached to the septum we have the septal leaflet. So the portion of the annulus which dilate is this one. I hope you can see the cursor of my mouse. So the anterior-posterior portion of the annulus. Here you can see more in detail the anterior leaflet and the attachment of the chordae tendinae to the free edge of the leaflet. The same for the septal. The septal is more attached to the interventricular septum and receive chordae directly from the septum itself, and this is the posterior leaflet. You can also see that the tissue of the leaflet is quite thin, quite fragile if compared to the mitral valve. Here you can see the three commissures marked. The commissures are really important for some intervention as a reference. And here you can see another really important anatomical marker, which is called triangle of Koch, which is an anatomical triangle marked from the basis of the septal leaflet, the coronary sinus, and the so-called tendon of Todaro. It's important because at the apex of this triangle, there is the atrioventricular node, which actually we don't see when we open the heart, but we can identify it with this reference. And now I would like to show you some target of the interventional device that we have. For example, when we do a leaflet repair with a mitra clip, we approximate the free edge of two leaflets. In this case, for example, anterior and septal leaflets. This is what we do with the mitra clip in tricuspid. Then I give you some example of annular devices. For example, the tri-cinch device allows the operator to perform a plication of the annulus in this direction, so from the anterior to the septal direction. It's a sort of plication of the valve. The tri-align is another annular device that allows the operator to perform a bicuspidalization of the tricuspid valve by plicating the posterior leaflet in this fashion, and therefore reducing the annulus and the valve area. And then, for example, by performing a direct annuloplasty with cardioband, the band will be implanted from the anteroseptal commissure, so from here to the posterior septal one, and then by adjusting the size of the band, the leaflet will be then forced to co-opt. Another really important anatomical structure in contiguity with the tricuspid valve, as you mentioned before, is the right coronary artery. Here I'm opening the right coronary artery from the aorta. And first of all, you can see that the right coronary artery is surrounding at least 2/3 of the tricuspid annulus. So all the anterior and the posterior part of the tricuspid annulus are surrounded from the coronary artery. And here you can see a light in the endothelium of the coronary. So the contiguity of the right coronary artery and the tricuspid annulus is much more pronounced than the one between the circumflex artery and the mitral annulus, if we compare mitral and tricuspid. So the risk of having problem of impinging the tricuspid, the right coronary artery by doing a tricuspid annuloplasty, either surgical or transcatheter, is much higher than the one that we have on the left side. And here you can see I'm stitching with a needle the coronary, and you can see how close it is to the annulus, and this red band is marking, surrounding the annulus in correspondence of the artery. If we open the right ventricle, we can observe the subvalvular apparatus. You can easily see that the septal leaflet receives chord directly from the interventricular septum here. And here you can see this big papillary muscle, which is the anterior one, is giving chord to posterior and anterior leaflet. And then there is a third one, normally smaller papillary muscle, but there is a lot of anatomical variability. Here you can see the valve opened, the 3 leaflets. You can appreciate again the close proximity between the right coronary artery and the annulus inside. You can see this band crossing the RVOT, which is the moderator band, that somehow prevent RV to dilate. And then you can see the surgical instrument going in the RVOT through the pulmonary valve here. And it's important to notice that there is a remarkable distance between the tricuspid valve and the pulmonary valve, and this is really different from the left ventricle, where we don't have this space separating the mitral and the aortic valve. And this is why, even if we put a huge device in the tricuspid valve, we won't occlude the RVOT. And here you can see the tricuspid valve, which is 3 leaflet, similar to the aortic one. I think we can somehow close the anatomical section with another multiple choice question. Which is the most important anatomical challenge for transcatheter annuloplasty devices? Here you can see 4 possibilities. The first one is the proximity of the right coronary artery. Then we have the fragility of the valve leaflets. Then the 3 leaflet configuration of the valve, and then the complexity of the subvalvular apparatus.
So thank you for that masterful overview of the anatomy, Maurizio. Really beautiful demonstration, not only of the dissection, but also the anatomical relationships of the tricuspid valve. Thank you so much for that. While we're waiting to see whether people have been listening to what you've been educating them on, there was a question from one of our UK participants actually asking whether the UK NICE guidelines are broadly corresponding with those from the European Society of Cardiology. Well, I'm pleased to tell you firstly that for the time being at least, Britain is part of Europe, and we therefore do adhere as a British Cardiovascular Society to the European guidelines. But in fact, there are no specific NICE guidelines relating to valvular heart disease, and that deficit is going to be addressed imminently by a new NICE guideline working party that is just in the setup phase right now. The project is going to be led by Dr. Madalena Garbis, who many of you will know from the Euro-Echo and European valve movements. But it will be some years until the guidelines are complete, perhaps 2020 or even 2021. So watch this space. So in terms of the responses to your question, Maurizio, I'm pleased to tell you that over 2/3 of the audience were listening to you, and they feel that the proximity of the right coronary artery is the most important technical consideration in transcatheter interventions. Now, before we get into the cases, we've got numerous very important other questions, and they're going to come to both of you. But I'm going to come back to Becky first of all, because some of them relate to the imaging and the assessment of physiology. So the first question, Becky, is how do we distinguish TR, which is severe, related to valve or right ventricular disease, as opposed to severe TR, which is secondary to pulmonary disease? Can you help us with that one?
Yeah, that's a great question, and I think they're related. It may be quite difficult to tell the difference, but when you look at the right ventricular morphology, it seems as though with pulmonary hypertension, the right ventricle, it turns out, is very sensitive to afterload, to pressure load. It'll tolerate the volume load a lot longer than it will the pressure load. And one of the reasons for that is that if you think about the physiology of the heart, the right ventricle has to pump the same stroke volume into the pulmonary circulation, but against a closed mitral valve. And so consequently, all of the stroke volume that's the same as that going out the left ventricle has to be held within the pulmonary circulation in the left atrium. So consequently, any increase in pressure of the pulmonary circulation, any pulmonary vascular disease, or any reduction in compliance of the left atrium or high left atrial pressure, so any diastolic dysfunction, anything that could cause post-capillary hypertension as well as pre-capillary hypertension will end up changing the morphology of the right ventricle. And that change in morphology is going to be seen typically by the displacement of the papillary muscles and tethering of the leaflets. If we don't have a lot of tethering of the leaflets, then it may be pure annular dilatation or a less significant pulmonary hypertension.
Okay, that's fantastic and very clear. A related question is how we account for the severity of right ventricular function or dysfunction in our quantitation of the severity of TR in the way that we might do with the left ventricle in mitral regurgitation. Is the paradigm the same in the right heart?
That is a great question. And again, I think we're embarking on this one valve disease where we still are learning about pathophysiology. So right now, by echocardiography, you have tricuspid annular plane systolic excursion. You have tissue Doppler S prime. You have fractional area change, all on two-dimensional type imaging. And yet this is a three-dimensional structure. So other parameters like global longitudinal strain, which we now know is very important on the left side, will now become also important on the right heart, in addition to the volume assessments perhaps by CMR or three-dimensional echocardiography. So the RV assessment of RV function will be hand in hand, just like on the mitral side, with the assessment of tricuspid severity, because in addition, the right ventricle is so sensitive to pressure. So if you reduce all of the tricuspid regurgitation and you take away that low pressure sink, now all of a sudden you've increased the afterload to the right ventricle. And if you don't account for that increase and you put, let's say, replace a valve in the setting of a very bad RV, then you may actually do the patient harm.
Okay, thank you so much, Becky. So, Maurizio, we've got some questions here which relate perhaps a little bit more to anatomy, and we're beginning to move into the area of procedures. But is there a clinical relationship between tricuspid regurgitation and disease of the sinoatrial node? Do the two go hand in hand? If you've got valve disease, does it mean you're going to have problems with heart block or bradycardias? Do they go together?
There is no clear relationship, I would say. They are connected, of course, because if you have first atrioventricular node and you get a pacemaker, then your chance to have tricuspid regurgitation is going to be much higher, partially due to the desynchrony induced by the pacemaker, partially due to the interaction of the pacemaker leads to the valve itself. And then, of course, also the opposite. If you do an intervention on the tricuspid, either transcatheter, either surgically, your chance to have an AV block after the intervention would be, let's say, increased because, of course, we are going to manipulate around the atrioventricular node. But
Okay. So. The other thing, of course, is that both are diseases of the elderly and degeneration.
Sure.
So, the two may go hand in hand in clinical terms, but not necessarily in anatomical terms.
Exactly.
Yeah. And then be careful what you say in answer to this question, because Becky is a non-invasive imager. But do you see a role for right heart catheterization in the assessment of patients with tricuspid valve disease?
We are still in a phase in which we are learning which patient could benefit and which are the parameters that we should look at in deciding our indication. So at this stage, I would say yes, most of the center in the workflow in deciding which kind of treatment and whether to treat or not are performing on a routinary base right heart catheterization.
So what do you do in Zurich? If you're planning
normally we do it.
A cardioband procedure, you normally do a workup right heart cath?
Yes.
Okay. Very good.
I mean, I would agree with that anyway, because I think there is some difficulty in our estimating pulmonary artery pressures in the setting of torrential tricuspid regurgitation. And so you do want to have a good baseline assessment of pulmonary hypertension.
Okay, so that's a very clear response. Thank you. So we've got lots of other questions relating to imaging, which is no big surprise because this is an imaging webinar, of course, and I do want to cover as many of them as we can, but equally I want to make sure that we cover the cases, if only quickly. We've got about 30 minutes left, Maurizio and Becky, so we're comfortably on track. But maybe we should move to the first case now. We'll make them quite quick. We'll aim for them to be 6 or 7 minutes each, and then we'll have plenty of time for questions at the end.
Okay, then the first case is a surgical case. We said already that surgery is carried out with high risk of morbidity and mortality, but still we have some patients that could benefit from surgery. In this slide, really quickly, you can summarize the technique that are used to fix functional tricuspid regurgitation. Most of them address annular dilatation by means of annular prosthetic ring implantation or by means of suturing. Some of them address also the tethering. Some of them, of course, replace the valve if the disease is too advanced. And the first case that I want to show you is a quite common clinical example that we see in almost our daily clinical practice. A young patient who got already 2 open heart surgery on the left side of the heart. So she got 2 mitral operations many years ago. She also got a pacemaker implantation some years ago in the postoperative course. And now, many years after the first surgery, she's coming back to us with severe symptomatic functional tricuspid regurgitation, ejection fraction which is moderately depressed, and also some kind of pulmonary hypertension, not too severe, but 45 millimeters of mercury. She's really symptomatic. She doesn't reply too much to medical therapy. STS score is moderately high, I would say. Here you can see the preoperative echo. So you see clearly that the annulus of the tricuspid valve is quite dilated. We will see later on how much. You can see that the entity of TR is massive, so it's really severe TR. You can also see that the transvalvular leads of the pacemaker is somehow interfering with the valve leaflet. So you can see that it's not only a functional etiology, there is also a iatrogenic component. You see here in this 4-chamber view, there are a lot of ways to assess RV function, but none of them are really validated in severe TR. So in surgery, we pretty much look also at the morphology of the RV. And here you can see that RV is still small and is contracting well. So this is a kind of picture that we like to have before moving towards surgery, despite the number that we can measure. You can see that the pacemaker leads interfere with the septal leaflet for sure, but probably not only with the septal leaflet. And you can see that the annulus is in the 4-chamber view quite dilated, 46 millimeter, with a tethering which is almost 1 centimeter, tethering high. So this is a case in which, due to the large annulus and the advanced tethering, most likely we would not do only annuloplasty, isolated annuloplasty to fix the problem, but we would do also something to fix the tethering, like enlargement of the anterior leaflet with a patch. And actually, I'll show you what we did. This is an intra-procedural movie. This patient was operated no more than 2 weeks ago in our center. Here you can see the confirmation of the huge tethering of the valve. You can see the pacemaker lead interfering with the valve. Most of the case of isolated tricuspid surgery can be performed on the beating heart with heart-lung machine. And this is something that we like to do if the patient has some degree of RV dysfunction, because we don't need to stop the heart. The leaflet that I'm now taking with the forceps, so the one up is the anterior leaflet. You can see that it's really tethered towards the valve. So that means that there is a displacement of the anterior papillary muscle causing tethering of the valve. The stitches that you see that we have put are the stitches for the annuloplasty. And here on the right, you can see the pacemaker leads crossing the valve. Now I'm detaching the basis of the anterior leaflet. And through this hole, you will see now the subvalvular apparatus. So you will see the tethered anterior papillary muscle. And actually, what is done with this technique is to enlarge the surface of the anterior leaflet. So this hole will be covered by a pericardial patch. So here you can see the papillary muscle where my mouse is. You can see the trabecule of the right ventricle really well. This is a pericardial patch, which is basically handmade. It's a heterologous pericardius. It's a biocompatible material, of course. And then this is sutured by a running suture in the middle, in the body of the anterior leaflet, in order to augment the surface of it and to give to the valve more coaptation area. So if you extend the anterior leaflet, then the anterior leaflet will coapt more against the septal and the posterior. In this specific case, of course, here you see the completion of the repair. So now the patch is in place, so the anterior leaflet is expanded. This is a sizer to decide which size of ring annuloplasty to put, because of course there is also huge annular dilatation, so we should address also the annular component. And now at the end, the pacemaker leads are fixed in the commissure in order to avoid any interference of the leaflets with the leads. Also notice that any tricuspid prosthetic ring that we use is incomplete in order not to interfere with the atrioventricular node, which is located more or less here. But of course, doing surgery on the beating heart allows the surgeon to see if you create atrioventricular block, you see it because the heart stops moving in sinus rhythm, so you can realize it. And this is the final result with a nice closing of the valve and basically no residual TR. So these are the key points, I think, are quite general. Isolated tricuspid surgery is usually carried on with high risk. Assessment of RV function and tricuspid anatomy is fundamental for the planning and for the indication. And then, as Becky already mentioned, valve tethering is the main predictor of TR recurrence after repair.
Thank you very much, Maurizio. Beautiful presentation and also some beautiful images from the OR. Can you tell us, do you rely on your imaging colleagues in the OR to guide you through a tricuspid valve surgical procedure, or is it a more traditional surgical hands and eyes task?
I would say both of them. What I, of course, rely on the preoperative echo is the visualization of the RV function, the measurement of the tethering, so how tethered are the valve, the leaflet, because if the tethering is more than 0.8, let's say, most likely you would have to add something on just annuloplasty or maybe to replace the valve. And then, of course, also the annular dimension are really important in guiding your decision.
So that's more pre-procedure rather than peri-procedure?
Yes.
Yeah, okay. Is that your practice in Colombia, Becky, or are you in the OR guiding the surgeons as well as in the cath lab guiding the interventionists?
Yeah, I think most of the decisions are made by the surgeon before they get in there, as it should be, as the hemodynamics of tricuspid regurgitation are very sensitive to load, and so to both preload and afterload. And so many of the decisions have to be made beforehand. But I think that that's one of the issues. If the surgeon doesn't realize that the annulus is indeed dilated, but once they get in, they don't see a lot of tricuspid regurgitation, they may not repair the tricuspid at the time of the mitral valve surgery, and that leads to our problem, which is that now we have residual tricuspid regurg after the mitral valve surgery. So I think that pre-procedural planning, just as Maurizio has said, is extraordinarily important, and that the surgeon participate in that pre-procedural planning.
And a quick question in response to one of our participants, Becky, but would you ever say the right ventricle is so bad that the patient should not have an intervention, even if they're in their mid-50s, like this particular patient? Would you ever advise not to do anything because the right ventricle is effectively not going to recover?
Well, so we don't really have a good handle on what parameters will predict recoverability. And I think that's one of the things that we're trying to study and that we're trying to learn now. Because we know, for instance, in patients who have lung transplants, their right hearts start out looking very bad and very dilated and hypocontractile, and yet they're able to recover after the lung has been transplanted. In addition, the right heart doesn't tend to have a lot of calcification or scarring or fibrosis, and therefore technically it should be recoverable, but we haven't yet identified which parameters to measure that predict recoverability, and I think that's one of the main areas of research at this time.
And can magnetic resonance help in the way it can in the left ventricle?
Yeah, we're not sure, except that because of the lack of fibrosis and typically of the septum, it tends to of the right ventricle, it tends to maybe fibrose only along the attachment to the septum. We're not sure that CMR is going to be the answer, but we're looking at other more functional parameters like RV-PA coupling parameters, or I'll show you later on RV-DPDT, which is the change in pressure over change in time, and how well the ventricle is actually able to contract against a pressure.
Okay, fantastic. So let's move forward with case 2, which takes us into the field of the very elderly with tricuspid valve disease and the challenges that they present and some of the technical solutions which are coming our way. Becky.
Yeah, I'd like to go ahead and present one of our cases. This is a 92-year-old female who presents with worsening dyspnea and fatigue. No acute episodes of right heart decompensation, but clearly progressive disease. She has a number of comorbidities, as most of our patients do: hypertension, hyperlipidemia, diabetes, in addition to being in persistent atrial fibrillation, and then has had cardiopulmonary bypass surgery for her coronary disease with preserved ejection fraction of 65%. She does at this time already have renal dysfunction. Her baseline creatinine is 1.6, and in that setting also of an echo showing severe tricuspid regurgitation, only mild mitral regurgitation, and moderate aortic stenosis, so nothing to intervene on the left side. The transthoracic echo, just wanted to remind you that because the tricuspid valve is very anterior, it is the most anterior and apically positioned valve in the body, that it is easily imaged by transthoracic echo. These are inflow views, apical views, short axis views, all able to assess the severity of regurgitation. But in addition, we use echocardiography, as we've already discussed, to assess right ventricular function. This patient and size. This patient had an RV size that you can see here with a mid diameter that is dilated in the setting of a right ventricular basal diameter that is mildly dilated. So moderate dilatation of the mid, mild dilatation at the base, and then an annulus diameter that is indeed significantly above normal. The RV function we assessed by both TAPSE, which is tricuspid annular plane, systolic excursion. That is typically reduced once the patient has had any kind of left heart surgery and a pericardectomy. So you lose the pericardial constraint, you'll lose your TAPSE. So we don't like to use TAPSE after bypass surgery. Instead, we'll use tissue Doppler S prime, fractional area change, global longitudinal strain, as you can see in the moving image here, and then another parameter that we like, which is the RV, change in pressure over change in time. And for that, we use the CW of the TR velocity profile. All of those parameters were normal in this patient, but she had an estimated PA systolic pressure of 65 millimeters of mercury, which basically will exclude her from many of the tricuspid trials that we have out there. In addition, her tricuspid morphology assessment showed that the tenting was not severe at only 0.44 centimeters. Again, remember 0.8 is the cutoff where we believe that there'll be recurrence with an annular device, and also that will predict failure of those devices. The tenting area, again, also not severe. Next slide. So the question to our audience is, what do you think the etiology of the tricuspid regurgitation is? Primary tricuspid valve disease, secondary disease in the setting of left heart disease, secondary disease in the setting of right heart disease, pulmonary hypertension, or in the setting of atrial fibrillation and chronic atrial dilatation.
So that's a tricky question there, Becky, but while we're thinking about it, what do you mean precisely by the term primary tricuspid valve disease?
Primary disease is a disease of the valve leaflets themselves. You can divide it roughly into two categories, the acquired and the congenital. Congenital includes Ebstein's anomaly, tricuspid valve tethering associated with VSDs or ventricular septal aneurysms. And then the acquired disease are the ones that we're most familiar with. So the rheumatic disease, endocarditis, and then the one that Maurizio showed, which is pacemaker-related primary tricuspid valve disease. So the pacemaker is actually causing leaflet tethering or subvalvular tethering or perforation even that causes regurgitation, and that's all considered primary disease.
That's very clear, thank you. I'm going to make you chuckle now because our audience is split four ways between options B, C, D, and E. So you better enlighten us and tell us exactly your interpretation in this patient.
I would say that they're probably all right. The issue with secondary disease is that often we will see patients with multiple possible etiologies of that secondary disease, and frequently we can't pinpoint exactly what it is. So remember, this patient has had coronary disease, has hypertension, and therefore may have diastolic dysfunction. In addition, the right heart we showed was dilated, probably secondary to some pulmonary hypertension. And then in addition, she has chronic atrial fibrillation. So I think the audience is very astute, to tell you the truth, and it's difficult to say that it isn't all four of B, C, and D, as well as E, that accounts for the disease. But I wanted to draw your attention to the idiopathic functional tricuspid regurgitation, and that is associated with age and atrial fibrillation. But I think we're learning more and more about heart failure with preserved ejection fraction. And in that setting of hypertension with increased left atrial pressures and increased left atrial filling pressures, we now are seeing post-capillary pulmonary hypertension that is then also seen by the right heart, causing right heart dilatation, annular dilatation, and tricuspid regurgitation. So again, I think all four diseases are indeed possibly playing a role in this particular patient. The TEE views have been pretty well defined. There are now four different levels that we can use. The mid-esophageal view, so this is obviously the pre-procedural imaging for the intervention that we propose, as well as the deep esophageal views. Those are one of the most important views that we have, because as you go deeper, the esophagus gets closer to the tricuspid valve and eliminates having to image through the left heart in order to get the tricuspid leaflets in view. In addition, transgastric and deep transgastric views are one of our most favorite views, since again, the tricuspid valve sits on the diaphragm and allows us to see those leaflets very, very well from a transgastric view. We love to do three-dimensional imaging. Three-dimensional imaging is essential in these valves that could be sometimes two leaflets on a tricuspid valve, maybe only 65% are three leaflets, and then there are four leaflets and five leaflet valves, or significantly cleft valves that we see very frequently. And therefore, three-dimensional imaging allows us to identify the leaflet morphology much better and identify where the leak is. That will also tell us which device might be the most effective. So in this case, the 3D color Doppler EROA suggested about a 1 centimeter squared regurgitant orifice, again, roughly 1.8 times that of the PISA. And the 3D quantitation confirmed about a 1.1 centimeter squared. The color Doppler, again, about 0.9 centimeters squared. All of those point to massive amounts of tricuspid regurgitation, which have not been previously well described in our guidelines. We've used terms mild, moderate, and severe, and yet the patients coming to us and to Maurizio tend to have much more severe regurgitation. They've been out there a long time. We've been underdiagnosing based on echo, and so the massive and torrential categories are an attempt to better describe the severity of disease. In this particular patient, again, without access to the transcatheter devices in the setting of some pulmonary hypertension, we chose to use compassionate use navigate or gate valve valve, which is a transcatheter tricuspid valve replacement device. This is a valve that is only 2 centimeters or 2.2 centimeters in height. It is equine pericardium. It has a 42 millimeter introducing catheter at this particular time, and has 2 degrees of motion at the tip only. So next slide. In this particular case, we use the CT pre-procedural imaging in order to confirm the size that we wanted to use, but also to plan for the atrial access. This patient had transatrial access, typically right about at the location of the insertion of the superior vena cava into the right atrium in order to get coaxial with the annular plane of the tricuspid valve. Next slide. Throughout the procedure, we heavily use echocardiography in order to guide the positioning of this very short device. So it being only 2.2 centimeters in height, with a natural displacement of the septal leaflet, we now have a pretty narrow range within which to implant the device, and we use advanced TEE modalities, and this is real-time MPR multiplanar reconstruction of the three-dimensional image. Again, this is using a GE device, a GE imaging machine, which their MPR is called FlexiSlice. The Philips MPR is called Multiview. And all of these allow us to reorient the two-dimensional image based on what we see on the three-dimensional image, or just to reorient based even on the two-dimensional images. We were successfully able to implant this device in the tricuspid annulus, and as you can see here, in the setting of no regurgitation left, this right ventricle is functioning beautifully. This patient did extraordinarily well, was discharged within a few days, and by report within a week was able to walk around and do all of her shopping, which is her main complaint at the time of presentation. So this was a very successful device, peak and mean gradients of 1.5 and 0.3 millimeters of mercury in the setting of no significant residual regurgitation.
So there's an exciting emerging transcatheter tricuspid valve replacement. Very quickly, Maurizio, just tell us an alternative approach in terms of valve repair, just in 2 or 3 minutes. Just give us a tantalizing look at a repair technique that's in your hands.
Yeah, very quickly, I'll show you this device, which is called TriCinch, that actually is a annular device that allows the operator to perform an annular application and to force the leaflets to co-opt by reducing the anteroseptal dimension of the tricuspid valve. The annulus is punctured through a femoral venous access, and then a coil is implanted in the pericardial space, as you can see from the animation. And then by applying tension, the annulus is cinched, is remodeled, and the valve is forced to co-opt. And then the tension applied is maintained by the implantation of a stent in the inferior vena cava. I'll show you quickly a case that we performed some months ago in a patient, again, an elderly patient with functional TR, really symptomatic, with no further medical option. Of course, high risk for conventional surgery, massive TR, as you can see from this 4-chamber view, moderate pulmonary hypertension. CT planning, as for Navigate, play a fundamental role in selecting patients for this kind of technology. We basically perform CT to assess feasibility, but also to decide which is the ideal target for each patient and how far the coronary artery is. And then based on CT planning, basically we are able to decide whether to puncture the annulus. Here you can see how big is the coronary artery, the right coronary artery in this specific patient. And then the device is inserted from the groin in the femoral vein, and the right atrium is accessed through the inferior vena cava. I would point out that to do all annular procedure, we use also ICE. We find that a combination of TOE and ICE are useful for annular procedure, because in some patients, TOE doesn't allow to see very well. And here you can see the puncture of the annulus. We always inject some contrast dye to confirm that we are in the pericardial space, and then once we access the pericardial space, we open the coil. Here you can see TR before applying tension. And now you can see the tensioning of the tri-cinch device. You see, we are pulling slowly back the device, and here you see the coil in the pericardial space, and by progressively pulling, you see the reduction of the annulus in this anteroseptal dimension. And then once we are happy with the result in terms of annular reduction and TR reduction, the stent is deployed in the inferior vena cava in order to maintain the tension. This is the final check to the right coronary artery, which is patent, so no problem with the flow. And here you can see the pre and post echo, which I would say a quite remarkable result in an inoperable high-risk patient. And all in less than 1 hour. This was a smooth case.
So certainly these procedures are feasible, they're very exciting, but they're held in the hands of super specialist expert reference centres at the moment. Just to give our participants a feel of the scale, Maurizio, how many of the tri-cinch devices have been done worldwide?
Worldwide, about 15 cases with the new generation device. With the older, about 30. With this device, about 15.
So we're talking about a set of patients which amount to many hundreds of thousands, if not millions worldwide. But we're also getting excited about techniques that have been used in less than 100 patients.
Yeah, we are really in an early feasibility phase of the...
phase,
yes.
Exactly. Now we have about 5 or 4 minutes to go, and I want to ask you some really quick questions with some quick answers so we cover as many as possible. Do you think that dysynchrony of the ventricle or the septum could have any impact on the durability of transcatheter devices?
Most likely, yes. I think that it has an impact in the development of TR in some patients, and most likely could have also an impact in the durability. We don't have this information, but most likely, yes. Okay,
and Becky, it's been pointed out that TR is a dynamic valve lesion.
Yes.
Do you think that stress echo has any role, or exercise echocardiography specifically? That's a question from Mexico for your reference. Is there a role of exercise or stress echo in assessing these patients?
I think there will be. I don't think that we have many guidelines right now that are using stress echo in this setting. But we know that with exercise, we do increase not only systemic pressures, but pulmonary pressures, even in normals. And perhaps that's enough to not only uncover RV dysfunction, but also more significant tricuspid regurg. So I do believe that we will be looking at stress echo as one of our pre-testing modalities to assess the applicability of some of these devices.
Okay. And can you get good 3D reconstructions in patients with atrial fibrillation is another specific question.
Yeah, I think that actually for, so there's two questions there. If you're looking for right ventricular volumes and right ventricular ejection fraction, I think that three-dimensional echo is going to be perhaps even better than CMR, since obviously you need to look at just single beats, which isn't typical for CMR, where they're averaging beats together. So atrial fibrillation becomes a problem for CMR, whereas for echo it's not. And then for the effective regurgitant orifice area, so for color Doppler, which is where I think they were going, because the systolic time interval tends to remain relatively constant in the greater plan, and it's really the diastolic time interval that varies. Systolic TR is actually pretty well imaged by color Doppler, even if you splice together subvolumes.
Okay, and then I'm going to bridge you into your final slides, Becky, because somebody wants clarification about the distinction between physiological tricuspid regurgitation and pathological tricuspid regurgitation. And we're going to project your first slide here about disease progression to help you with your answer.
Great. Yeah, I think in the chart that you see, we've attempted to, and this was Maurizio also has described kind of staging of the disease, because as you know, most patients have a little bit of tricuspid regurgitation. And so as you go from stage 1 to stage 2, where now it becomes a little bit more pathologic, there's not a lot of other abnormalities that you see. It may just be the regurgitation itself. But as we progress in these stages, you can see that we believe that you get more and more right ventricular dysfunction, and what comes first, the chicken or the egg, is not as clear. But clearly, as we progress, the diuretics which used to treat very well the early stages no longer become effective. And here's where you might be required to treat the pulmonary hypertension, for instance, but really where surgery or an intervention might play a role. The problem is that in stage 4 and stage 5, these patients have multiple comorbidities which make their surgical risk very high. Consequently, these transcatheter devices may be the most appropriate. And early on, it could be any device, an annular device, a leaflet device, a replacement device. But as you get more progressive disease with RV dilatation, now here's where the annular devices may not be effective, as we have already learned from our surgical colleagues, but the leaflet devices and replacement devices are still effective. And then late in the disease, you may actually have a situation where the leaflet devices and the replacement devices are no longer appropriate, particularly if the RV function is severely reduced and you take away all the regurgitation and increase afterload. And here's the role for palliative devices like keyhole devices or the forma spacer device. And so I think that there's a lot of room for all the different devices that are currently in development. And as we learn more about the tricuspid valve and RV pathophysiology, we'll be able to pinpoint which device is most appropriate for each patient.
So there you have it, a disease which is very, very common in routine clinical practice, a disease that needs much greater awareness, much more memorability, if we can coin the phrase, and a disease where imaging is of fundamental importance in establishing the diagnosis, in assessing its severity, monitoring its progression, and allowing the planning of procedures, not only conventional surgical techniques, which are long well established, but also innovative transcatheter techniques, which in maybe the next 10 to 20 years could take us to where we are with TAVI for the aortic valve in 2018. Thank you for joining us. Thank you to Maurizio. Thank you to Becky. And I apologize for the questions we haven't covered, but I wish you all a very good evening. Thank you.